We present the rare case of complete uterine inversion in a young non-pregnant patient managed laparoscopically. This is the case of a 24-year-old patient, with a past history of a granulosa cell ovarian tumor managed with laparotomy, including a right adnexectomy, omentectomy, and right pelvic lymphadenectomy, followed by 6 cycles of chemotherapy. 4 years later, she was admitted as an emergency to the Gynecological Oncology department of our hospital, with sudden onset of intractable uterine bleeding. On clinical examination, a necrotic, hemorrhagic mass was observed, protruding from the vagina. It was then decided to perform a transvaginal total removal of the mass. During this attempt, accidental perforation of the uterus was observed, and diagnostic laparoscopy was performed. During laparoscopy, a complete uterine inversion was found, resulting in gross distortion of the pelvic anatomy. Mild maneuvers were performed to correct the inversion by pulling on the round ligaments and exerting digital vaginal pressure, but these were unsuccessful. Several sutures were placed for hemostasis, and it was decided not to perform any further manipulations, wait for the final histology, and refer the patient to our unit for laparoscopic management. At repeat laparoscopy, the uterus was found totally inverted with complete loss of its fundal shape. Non-puerperal uterine inversion is exceptionally rare, and the true population incidence remains undefined. The evidence base is limited to approximately 300 published cases across systematic reviews, with substantial publication and ascertainment bias. The round ligaments were divided entering the retroperitoneal space. The ureters were recognized and dissected. And the uterine arteries were temporarily clipped bilaterally. Using a bowel manipulator as a guide, the rectovaginal space was opened and dissected as far distally possible to facilitate maneuvers. It is described that the cause of this pathology could be a fundally implanted intrauterine mass that generates sustained downward traction on the uterine fundus. Progressive fundal thinning, cervical dilatation, and expulsive myometrial contractions facilitate invagination of the corpus through the cervix. Tumor bulk, pedunculation, and transcervical extrusion amplify traction. Sudden increases in intra-abdominal pressure may precipitate complete inversion. The rectovaginal space was displaced posteriorly, due to the protrusion of the uterus into the vagina, and presence of a thick constriction ring. An effort to manually reverse the uterine inversion with digital vaginal pressure at this stage was unsuccessful. In view of a planned division of the uterocervical constriction ring, diluted vasopressin was injected, and a posterior uterine incision was made, followed by a second unsuccessful digital vaginal maneuver. The uterine cavity was then entered to identify the anterior part of the constriction ring, which was largely distorted due to the previous vaginal surgery. A smaller anterior incision of the constriction ring followed, resulting this time in a complete reversal of the inversion, revealing the damage inflicted by the previous procedure, and a largely hyperplastic endometrium. After removal of previously placed sutures, and reshaping of the uterus, the uterine wall was closed anteriorly and posteriorly, in 2 layers, with interrupted figure of 8 monofilament absorbable sutures. To reduce the possibility of inversion recurrence, a cervical circlage tape was then placed. Evidence on recurrence prevention is limited. Given the patient's age and desire for fertility, circlage was chosen to prevent fundal descent through a potentially incompetent cervix and reduce future cervical insufficiency. Removal of the uterine clips was followed with closure of the uterovesical peritoneal fold. And finally an anti-adhesive film was placed. At 6 months follow-up, MRI showed good restoration of the cavity and a fairly normal uterine shape. Although the patient did not show postoperative stability in her menstrual cycle, over a period of 12 months, she had her period 4 times. Surgical reversal of complete uterine inversion has been described mainly as an open procedure using either the Huntington's approach, which involves gradual upward traction on the inverted uterus, or the Halton technique, which involves a posterior incision of the constriction ring to facilitate repositioning. Vaginal approaches include the Spinelli and Kussner procedures, which use anterior or posterior cervical incisions to release the constriction ring and restore normal uterine anatomy. Only a handful of successful laparoscopic procedures preserving the uterus have been reported in the literature, none performed on a mutilated uterus such as in our case.